Welcome to the Foster Healthy Weight in Youth Training, Nebraska's clinical model to assess, prevent, and treat childhood obesity. I'm Dr. Joanne Schaefer, Nebraska's Chief Medical Officer and a family practice physician. Over the past few decades, childhood obesity has grown to an epidemic that is now a national health priority. 2 out of 3 adults are overweight or obese. Following their parents, 1 in 3 kids are overweight or obese. According to the Robert Wood Johnson Foundation, a recent study shows we are raising the first generation of youth who will live sicker and shorter lives than their parents. As healthcare providers, we see the impact this epidemic has on the children and the families we care for. It affects not only the physical and emotional health of children, but also children's academic and economic potential, as well as the overall health and economics of our communities. Healthcare providers play an important role in the prevention, assessment, and treatment of childhood obesity, and are important advocates in our communities. This training will show you how to effectively address in your clinic children who are overweight and obese using Nebraska's assessment, prevention, and treatment model. Throughout this training, you will hear from other Nebraska physicians who are integrating the model into their practices and advocating in their community. Together, we can develop a statewide effort to improve the health of Nebraska's children.
During this training, you will learn a comprehensive approach to address the growing epidemic of childhood overweight and obesity with your patients and families. The information presented is a culmination of national research, expert recommendations, Nebraska resources, and physician champions. This training was developed in collaboration between the Nebraska Department of Health and Human Services, Nutrition and Activity for Health Program, Creighton University School of Medicine, Children's Physicians, Live Well Omaha Kids, and Teach a Kid to Fish. By the end of this training, you will be able to describe childhood obesity as a national priority, the epidemiology and etiology of the childhood obesity epidemic, the role of healthcare professionals, the Foster Healthy Weight in Youth clinical algorithm to assess, prevent, and treat childhood obesity, the Nebraska Youth Physical Activity and Nutrition Assessment Form, and state resources. The information included in this program has been reviewed and approved for 1 continuing education unit or contact hour credit by the American Medical Association, Category 1 credit, Nurses Association, Commission on Dietetic Registration. When you have completed viewing the training video, visit the Creighton CME website at cme.creighton.edu to complete the evaluation and post-test to receive your continuing education certificate. 70% accuracy is required on the post-test. Over the past 20 years, the obesity epidemic has swept across the nation in the adult population in all states, as illustrated by the CDC obesity trend slides.
The CDC has some great information, mostly nationwide information about what's happened in the rates over the last 20 or 30 years. It starts out in the 1970s, about 5% of kids were overweight or obese, or 45% are obese. It's changed in the mid-80s to early 90s. It doubled to about 10%. Currently it's around 17.6% of kids being obese right now in the United States. If you add overweight, it's up in the 30s, I think 33% if you add overweight and obese. So 1/3 of the kids are either overweight or obese in the United States right now.
31.5% of Nebraska youth are overweight or obese. This percentile is greater in minority children and children who live in poverty who do not have access to healthy, affordable foods and safe physical activity opportunities.
And there's a good study by Finkelstein and some other colleagues about how much of a percentage of our healthcare costs is due to obesity. Right now they're estimating at this point it's 9%. It's probably going to go up higher in the next 10 to 20 years. That came out to about $147 billion a year, which is a huge number to get your head around, but if you divide that up by every man, woman, and child in the United States, that's $500 a piece it's costing each single one of us, and so that you pay that in your taxes and your health insurance premiums, and that's now. It's going to get higher in the next 10 to 20 years if we don't change anything. There's been estimates that's why is healthcare costs going up faster than the rate of inflation? One of the big contributors is the obesity epidemic. So.
The health and psychological consequences of childhood obesity are extensive. Obesity affects nearly every body system, including pulmonary, gastrointestinal, musculoskeletal, endocrine, neurological, renal, and cardiovascular systems. Diseases such as type 2 diabetes, formerly called adult-onset diabetes, are now being diagnosed in children in large numbers. Additionally, the psychosocial consequences of obesity can include eating disorders, depression, social isolation, and poor self-esteem.
Something that sometimes is very difficult to work with patients that we find with obesity and overweight is to see the self-esteem. A lot of patients comes with that they don't look at your eyes, they don't have eye contact. It's very difficult to get any words from them. And as soon as you start working with them, you start looking that the patient feel more comfortable with you, and they start having more, more relationship with you. But this is this is the consequences of basically of being the child that nobody wants to talk with, and to be the child that can't do PE because it's overweight and they get tired and they can run like the other kids. And that's something that we frequently see, and we have to address this topic when we are talking to them very carefully.
Obesity is the result of an imbalance of energy intake and energy expenditure. Genetics, environment, and behavior all contribute to obesity risk. The rapid increase in prevalence of children who are obese and overweight cannot be explained by genetics only. Changes in nutrition and physical activity behaviors and environments which are unhealthy have caused this public health problem to move to epidemic proportions.
The energy imbalance is what's creating the problem. And the energy imbalance is caused by too many calories in and not enough calories being burned. And if you look at why that's happening, it seems that it has to do, the two sides of the equation are driven by the amount of physical activity children and their families are getting versus the amount of nutritious foods that children and families are taking in. And a lot of research has been done on why this has changed over the last 20 years, and there are lots of different theories, but what we do know is that children are taking in excess calories compared to what they're burning every day, and that's consistently increasing over the years.
The environmental causes are ubiquitous shifts in food practices and the marketing of those unhealthy foods to children, even at very young ages. The changes in our built communities, increased opportunities for screen time. It should be reframed as an epidemic of poor nutrition and physical inactivity confronting all children.
If you look at the studies, probably the single biggest thing is the sugar-sweetened beverages. And that doesn't include just pop. People automatically think it's the pop, but it's not just that. It's also the sports drinks that everybody thinks they need a sports drink now, and most of us don't need something like that. It's in the juice drinks, like the High C, Sunny Delight, those kind of things. They're a lot of added sugar. It's not really juice. And in some of the energy drinks also. And so the average kid is getting, one of the statistics is that the average consumption of sugar-sweetened beverages has gone from about 70 calories per day on average up to 190 calories per day. And that's a 120 calorie per day increase, which doesn't sound like a lot, but over time that actually makes a pretty big difference. That's 10 to 12 pounds per year of weight gained if you don't do anything to account for that by either decreasing the consumption of something else or exercising that much more, which is quite a bit of exercise to burn off that extra 120 calories. So.
For smaller communities, the access to fruit and vegetables is not always consistent. And even in some of our inner cities, we'll see whole sections of the city that don't have access to all 5 food groups, including fruits and vegetables, within even a mile. So access to foods, including fruits and vegetables, is an issue. The amount of food we're eating also has increased dramatically. I remember when I was a child and would get a Coke, it was just this little teeny bottle. And now it's like 3 of those bottles is one size. And of course we call that portion size. And at restaurants or any place you go, you can observe that portion sizes are out of control.
The effect of advertising on children. pre-1980 there were limits on advertising to children, but those were removed in 1980, and so it became free reign to advertise whatever to any aged child. And so you can advertise directed toward a 5-year-old things that really wouldn't be safe for them to eat. There's some statistics like half of commercials that a kid sees on TV are food ads for things that are processed, sugar sweetened, things like that. And so there's a huge amount of advertising directed towards children. Yeah, we've seen a lot fewer kids walk to school. It was very common, 40 to 50% of kids used to walk to school in the 1960s, for example. Now it's less than 20% of kids walk to school. And so for whatever reason, due to the design of our communities, it's just harder to walk to school because of schools being on a busy road or not having sidewalks or parents not feeling safe letting their kids walk to school. We have a lot fewer kids walking to school. There's even interesting statistics. If a kid has a television in their room, in their bedroom, they have a more than 30% increased chance of being overweight and obese just because the television's in their room, and probably because they're spending more time watching that TV and seeing more commercials.
Some of the barriers that healthcare providers face in the prevention and treatment of childhood obesity are time, lack of resources, both evidence-based resources or interventions in the office, as well as resources and programs in the community to refer our patients to, and then also reimbursement. Obesity currently is not viewed as a chronic disease, and prevention services are not covered by most insurance companies.
Although these barriers exist, pediatric providers do not have the luxury to wait until these barriers no longer exist. Taking small steps and incorporating some or all of Nebraska's clinical model to prevent and treat childhood obesity will collectively have a big impact on pediatric practice in Nebraska to improve the health of our children. There are 4 defined roles of pediatric healthcare providers when addressing the childhood obesity epidemic. They are: 1. Assess. 2. Prevent. 3. Treat. 4. Advocate. Pediatric providers are uniquely positioned as a voice of authority and expertise for both the patients and families. Setting a practice standard to regularly address healthy weight and healthy behaviors will help families understand the importance and seriousness of a healthy lifestyle and healthy weight as a lifelong goal to prevent disease and maintain their health.
It's a very unique role that you have when you're a healthcare provider, especially when you're taking care of children. You have a direct link, you have a window into what are the barriers to that child's health. So your voice is their voice. And I think that is the most important role for me. I think that's the most important job there is to be that voice in the community.
The Healthy Weight in Youth Assessment, Prevention, and Treatment algorithm has been developed to assist the healthcare provider in addressing the childhood obesity epidemic at all well-child visits and other related office visits. The algorithm is available as a pocket reference and is more fully described in the corresponding Healthy Weight in Youth toolkit. Page 1 of the algorithm outlines the assessment steps. Assessment is divided into 4 steps. 1. Chart BMI percentage for age on all patients ages 2 to 18 presenting for well-child checks or with weight concerns. 2. Performing a clinical history and physical examination. 3. Assessing health behaviors and attitudes using the Youth Physical Activity and Nutrition Form. 4. Follow prevention and treatment algorithm to determine plan of action. The first step in the assessment for obesity is the calculation of the body mass index, BMI, defined as weight in kilograms divided by height in meters squared. The American Academy of Pediatrics recommends yearly calculation of BMI for all children ages 2 to 18 presenting for a preventive well-child examination. BMI is a reliable indicator of body fatness for most children and teens. It is an inexpensive and easy-to-perform method of screening for weight categories that may lead to health problems. For children and teens, BMI is age and gender specific and is often referred to as BMI percentile for age. BMI may be calculated using a mathematical formula or a BMI wheel calculator. Then plot the BMI percentile on age and gender-specific CDC growth charts and document the weight category. BMI percent less than 5th percent classifies the patient as underweight. 5th to 85th percent classifies the patient at a healthy weight. 85th to 95th percentile BMI documents the patient as overweight, and 95th percentile or above is classified as obese. It is important to chart the BMI percent and document the weight status category because in children, the significance of absolute BMI values changes with age. This is demonstrated here by the growth chart of this 10-year-old boy with a BMI of 23, placing him in the obese category. But at age 15 years, with a BMI of 23, the same patient is at a healthy weight. The next step in assessment is the clinical evaluation, which is composed of the clinical history, physical examination, and laboratory evaluation. Document the use of medications that are associated with obesity, including steroids, antiepileptics, and antipsychotics. Complete a family history to screen first and second degree relatives of all patients for obesity, type 2 diabetes, hypertension, hyperlipidemia, heart disease, early cardiovascular deaths, and strokes. If the patient's BMI percentile is at 85th or greater, then obtain a focused review of systems for snoring or sleep problems, headaches, abdominal pain, menstrual irregularities, hip, knee, or leg pain, polyuria or thirst, and symptoms of depression.
Some of the comorbidities that we see in our obese and overweight patients, we do a physical exam. We start looking at them. What we see is the darkness of the skin. That is what we call acanthosis nigricans, and that's a marker in the future for diabetes, and that's one of the things that we have to look at. The other comorbidity that we see frequently is an alteration in the lipid profile. And some of the patients that they are coming already with 240 pounds or overweight or obese, they already had increase of the cholesterol, and the other one will be the triglycerides. And it's very important to look the guidelines that the American Academy of Pediatrics has recently published, where we can find the value and the data for these values for cholesterol and triglycerides and HDL and LDL. The patients with obesity had the tendency to have a sleep apnea that is associated with snoring, and that's the way that we can find out. And for the snoring, we have to start looking a little bit deeper and ask the parents if they are waking up in the middle of the night and there is an association of sleep apnea. There are some GI problems. This patient complains about abdominal pain, and most of the times it's secondary to severe reflux because the overeating habits, they tend to have severe reflux, and we need to treat them with PPIs or Zantac.
In summary, to screen for comorbidities, look for the following signs on physical exam: hypertension, acanthosis nigricans, tonsillar hypertrophy, goiter, abdominal tenderness, hepatomegaly, bowing of the legs, limited hip range of motion. Examine optic discs for signs of pseudotumor cerebri if the patient is having headaches, and for signs of polycystic ovary syndrome, such as acne and hirsutism. Order fasting lipid panel on all overweight and obese patients. If the patient is overweight, has risk factors based on family history and physical exam, or if the patient is obese, then also order a fasting glucose and liver enzymes. Further laboratory studies should be based on physical exam and history. The Foster Healthy Weight in Youth Provider Toolkit contains supplemental reference materials to aid in the management of the obese child. This segment of the webinar will focus on how to use the Youth Physical Activity and Nutrition, or PAN, PAN form to assess health behaviors and attitudes. Developed at the Nebraska Department of Health and Human Services and tested at the Creighton University's Children's Physicians Pediatric Clinic, the PAN form is an objective assessment tool that facilitates the conversation around weight and nutrition and activity habits. The PAN form also is infused with consistent prevention and treatment messages, as it is a tool that integrates the expert committee recommendations in the clinic setting. The PAN form may be used in all pediatric patients ages 2 to 18 years, presenting for well child visits or with weight concerns.
Using the PAN form, we have been doing it for the last 2 years in our clinic, has been a very successful tool because we are being able to show them that you can see, like in a mirror, what are you doing currently, and what are the things or changes that you can make very easily. And it's a choice that you make. It's not a choice that I make. I'm empowering them to decide a change. I think it's really is a very useful tool. It takes you no time extra, because you don't have to ask about exercise or feeding habits or meals, or you don't have to ask TV time or screen time because it's in the PAN form. What you are going to do is the intervention, because you already has the data in the form. And if you do it in the right way, it's going to be 5-10 minutes of intervention. You are not asking a lot of questions because the parents have been already answered those questions, and the patient. Is the intervention what it's really helping us to do that?
The form has 2 sides and is printed with a carbon copy, so the top form can be sent home with the patient. The front assesses current information of the top 11 health behaviors associated with recommended activity and eating patterns that promote healthy weight and optimal growth and development. It is organized so the healthy behaviors are listed first, and the less healthy behaviors are in the lower part of the section. The bottom of the form has a numerical scale which assesses the patient and or parent's readiness to change any one of the behaviors assessed on the form. A separate column is provided for setting 1 to 2 goals with the patient, and a goal tracker section, which helps patients monitor their health behaviors. There is also a contractual signature box to be signed by the clinician and the patient to affirm commitment to goals set. Lastly, the back of the form is an educational and reference tool and includes age-specific physical activity and nutrition tables for patients and families. Let's take a closer look at the 11 health behaviors assessed on the form. The first section assesses physical activity and sedentary time. Daily physical activity includes moderate and or vigorous intensity activities such as active play, biking, brisk walking, running, etc. The form collects total minutes per day and days per week. The goal for daily physical activity is 60 minutes per day, 7 days per week. High-intense activity is a vigorous activity that is challenging, causes increased heart rate, fast breathing, and sweating. Any activity can be done at a high intensity. High-intensity activities are a part of the recommended 60 minutes per day, but the goal is to get high-intensity activity at least 3 times per week. Strengthening activity is an activity that creates a force, impact, or overload on muscles and bones. These include activities such as jumping, skipping, climbing, gymnastics, running, and weightlifting. The recommendation for strengthening activity is 3 times per week and can also be part of the total daily physical activity time of 60 minutes per day. Because national guidelines do not provide specific recommendations for 2 to 5-year-olds on high-intensity and strengthening activities, those behaviors should only be collected on patients age 6 or older. Screen time should be assessed for all patients and includes time spent watching TV, playing video games, and computer time. Screen time is assessed in hours per day, and the recommendation is that children 2 and older spend no more than 2 hours per day at a screen. Of the 7 nutrition behaviors on the form, The first 4 focus on those behaviors to encourage, and the last 3 are the behaviors to limit. Breakfast is defined as eating within 2 hours of waking, and the recommendation is to eat breakfast every day. Fruits and veggies are assessed in amount, cups per day or week, and not servings, and all forms should be counted, fresh, frozen, dried, or canned. It is recommended that kids get 1 to 2 cups of fruit per day and 1 to 3 cups of vegetables, overall intake based on the child's age. Milk or milk products include milk, cheese, and yogurt and are assessed in cups per day. The recommendation for milk or milk products is 2 to 3 cups per day of fat-free or low-fat milk, or milk, yogurt, and or cheese. Whole grains are assessed in frequency by times per day. Whole grains include whole wheat, oatmeal, brown rice, etc. Whole grains are recommended at 2 to 3 times per day. High-fat and sugar foods include foods high in added fats and sugars, chips, candy, fried foods, ice cream, etc. These foods are also assessed in frequency by times per day. The recommendation is to limit the consumption of foods high in fat and sugar, and so 0 to 1 times per day. Sugar-sweetened drinks are those beverages with added sugar and include regular soda, lemonade, fruit punch, sport drinks, and non-100% juice. These drinks are assessed in frequency by times per day. The recommendation is to limit the consumption of sugar-sweetened beverages, and so 0 to 1 times per day. The last behavior, eating out, includes those meals eaten out of the home or school and is assessed by days per week. The recommendation is to limit eating out, 0 to 2 times per week. Be sure to direct your patients and families to the back of the form for the age-specific physical activity and nutrition tables and further explanation on healthy eating and physical activity recommendations. Circling the age-specific column can help guide parents also to understand their child's specific needs. The PAN form can easily be integrated into a routine well-child visit. Step 1 of using the PAN form in clinic is to give the patient and or parent the form while in the waiting room and instruct them to complete the current activity column, or gray column, based on their health behaviors over the last 5 to 7 days. The nurse checks over the form for completeness and asks the patient and family if they have any questions. At the start of the clinic visit, the physician should thank the patient and or parent for completing the form and ask if they have any questions. Scanning over the form, compared to the Healthy Kid recommendations, reinforce their good behaviors by providing positive feedback. For example, great job eating breakfast every day. Provide neutral feedback or open-ended questions for behaviors which are not optimal, such as, your child watches 4 hours of TV after school. How do you feel about that? Using the readiness scale at the bottom of the form, determine if patient is ready or resistant to change. If they have circled 1 to 3, they are likely not ready for change. If they have circled 4 or 5, they are indicating a readiness for change. Ask permission by using questions such as, would you like to spend a few minutes today talking about changes you could make to improve your child's eating and physical activity level? If the patient and or parent is not ready, give neutral feedback such as, sounds like you aren't quite ready to make any changes now. We'll follow up at your child's next visit. Or, although you aren't ready to make any changes today, you might want to think about your child's weight gain and the importance of lowering his risk for diabetes. Goal setting using the PAN form should be self or parent directed. A column on the PAN form is provided for goal setting. If patient is ready for change, guide them in setting 1 and no more than 2 goals. It's important to guide the patient in making a reasonable and achievable goal. A 20 to 50% change from where the patient's current activity increases the chance of success. Too large of a change has less potential to become a long-term lifestyle behavior change.
Do you think you are going to be able to do it?
Yes.
Okay, remember that here we have the goals, and if you do it you just check, and if you're not doing it, that's fine.
Okay.
There are days that we're lazy, and we understand that, but the idea is that, you know, over the weeks that we're not going to see each other, probably you can do better, okay?
Okay.
And okay, I'm going to put here that you are going to increase veggies to 3 times a week, and I know it's going to be hard, but we're going to.
Once the patient has set a goal, be sure that both sign the form and comment on your commitment to helping them achieve their goal. Make a note of any referrals or follow-up plans in the box provided. Give the top copy to the patient and place the carbon copy in their chart. For a number of reasons, it can be difficult to counsel children and families on such a touchy subject as obesity. Remember to be empathetic, non-judgmental, and non-critical. Ask open-ended questions. Are you planning to make some changes in your eating and physical activity? Give affirmation. You're right, it's hard to make changes. Be reflective of patient-parent comments. Sounds like time and money make it difficult for your family to eat healthy foods. Then give summarizations that include patient-parent comments. From what you're telling me, you're willing to make a change to low-fat milk starting today.
Using the motivational interview techniques are the things that are really helping me during these 4 years that I've been working in obesity, to approach them in a very healthy way and trying to say, I'm just coming to help you and to see what you can do. It's not what I'm telling you to do. It's like, how can I help you to do what you decide to do?
It's important to know whether to set goals with the parent, the patient, or both. If the child is under 12, work with the parent or guardian. They control the foods coming into the home and access to physical activity, television, and other screen time. For the 12 to 14-year-old, work with the motivated person or persons, but be sure to interview the teen individually and ask about goals separately as well. Work with the high school-age teen in confidence. Ask the teen's permission whether or not they want to involve the parent. 3 key points are offered to successfully incorporate the PAN form into your clinic. 1. Find a champion. 2. Host staff training. 3. Establish protocol for your clinic. Change is hard for everyone. Using the team approach, having physician and clinic buy-in, and developing a protocol by using the algorithm will help you in dealing with resistance. To successfully incorporate the PAN form into your clinic.
Prevention in obesity is absolutely the most important thing because, as most of us know, once a child is overweight or obese, the road to getting them not being overweight and obese is absolutely a huge challenge that is something that is just not oftentimes very successful, particularly when it's severe obesity. So prevention is really the key, and that's something that, as a breastfeeding advocate, I absolutely believe in prevention. There have been multiple studies now showing the benefits of breastfeeding to prevent obesity, and in fact, in a pooled number of studies, up to 25% reduction in the chances of being obese as an adult happen for those who are breastfed ever. So for those who are breastfed ever, that's great news. And then for those who are breastfed exclusively, with every month that you are breastfed, you actually have even 4% lower chance of being an obese adult. So this is great news for people who are already breastfeeding, and great reasons for people to decide to breastfeed, not only because of all the other health benefits and other benefits. So one of the things that's very important for physicians and for families is to follow growth patterns and know what normal growth patterns are. On top of that is when you do discover that a child is overweight for their size, it's important to follow that and to specifically let parents know where the child is compared to other children at that age, where the child is compared to their height and where they should ideally be, taking into account all the variety in kids and different skeletal size and things like that. Most people really value their physician's opinion, and if they go to a physician who just takes a casual approach to breastfeeding, that somehow it's just a lifestyle choice as opposed to a medical decision, then they're not really serving the needs of that family very well. Physicians need to treat breastfeeding as another medical decision and be part of that decision and let people know truly what the benefits and what the risks of not breastfeeding are. And physicians also need to be educated about that themselves and be willing to refer people if they do have barriers to breastfeeding from an early age as well as through prolonged breastfeeding, because one of the biggest issues we have is continuing exclusivity of breastfeeding, meaning babies should be breastfed for 6 months with nothing else, and our numbers for that are actually really low, and a lot of that can be helped if we have supportive physicians that are educated and are providing moms with the information and supports that they need to continue exclusive breastfeeding beyond that first neonatal period.
A prevention and treatment algorithm has been developed based on the expert committee recommendations on the assessment, prevention, and treatment of child and adolescent overweight and obesity. It may be found on page 2 of the clinical algorithm. This section will go through the treatment recommendations for each weight category. If the patient is at a healthy weight or is overweight without risk factors, the prevention algorithm is followed. Assess health behaviors and attitudes using the PAN form. If the patient and/or parent is motivated to change, then proceed to goal setting using the PAN form. Prevention counseling includes delivering consistent, evidence-based messages to all patients regardless of BMI. These patients should also be referred to community resources and programs with the goal to maintain weight velocity. Follow up with an annual reevaluation. Consistent prevention messages are those that have been identified by the expert committee and the Centers for Disease Control and Prevention to prevent obesity and are unlikely to cause harm. Delivering 1 or 2 consistent prevention messages at each visit can positively reinforce goals or behaviors. In summary, encourage 60 or more minutes of moderate to vigorous physical activity every day, more fruits and vegetables, eating breakfast every day, and family mealtime. Limit screen time to no more than 2 hours per day. Limit sugar-sweetened beverages, high-fat and sugar foods, and eating out. A series of patient education postcards and office posters has been developed to complement the consistent prevention messages.
I can tell you that most of my patients that are obese or overweight, at least I maintain their growth velocity goes down and I maintain their weight. And that's one of the goals that I have in the clinical setting because I cannot put them in an exercise program. But I'm telling you that I've been able to do that in these 3 or 4 years that I've been working on that, and you can do it too.
The expert committee recommends a staged protocol for treatment, with the level of intervention to be based on a patient's BMI percentile and risk factors. For further information on the clinical management of the obese child, refer to the Foster Healthy Weight in Youth Provider Toolkit. For all patients who are overweight with risk factors or obese, follow the treatment steps along with the staged protocol. Assess health behaviors and attitudes using the PAN form. Set 1 to 2 lifestyle goals using PAN form if the patient and/or parent is ready for change. Refer to subspecialists for comorbidities and consider referrals to behavioral specialists and a dietitian. Refer the family to community resources and programs and deliver consistent messages. Stage 1, or Prevention Plus, occurs in the primary care office setting. There is more focused attention to lifestyle changes and more frequent follow-up. The weight goal is to maintain the patient's weight, then BMI reduction with growth. For follow-up, the family visits with clinician every 1 to 3 months. After 3 to 6 months, if no improvement in BMI, advance to the next stage. Stage 2, or Structured Weight Management, occurs in the primary care office setting. There are more structured behavioral goals, such as more physical activity, screen time, and nutrition changes, as guided by the physician or health professional specifically trained in weight management. The goal is to maintain weight, then BMI reduction with growth. The family is to follow up monthly with the clinician. After 3 to 6 months, if no improvement in BMI, advance to Stage 3. Stage 3 is evaluation and follow-up with a multidisciplinary team experienced in pediatric weight management. The weight goal is weight maintenance or gradual weight loss. Follow-up is weekly visits for 8 to 12 weeks. Stage 4, tertiary care center, is recommended for children with BMI greater than 95th percentile with comorbidities, refractory to stages 1 to 3 treatment, and children with BMI greater than 99th percentile who have shown no improvement under stage 3. The patient is evaluated by a multidisciplinary team with expertise in childhood obesity, working under a designated protocol. Additional stage 4 treatment options include meal replacement, very low-calorie diet, medication, and bariatric surgery.
Amanda, it's a 16-year-old girl that came to our clinic 3 years ago, and she was 300 pounds. And for a long time, I was able to continue having her with 300 pounds. Amazingly, she didn't have a big comorbidities except for a mild reflux and a little bit of asthma, but it wasn't really like huge hypertension or anything like that. And Amanda was able to maintain her weight, and I thought was a success for her and for us in the clinic, because she didn't gain more weight for at least 1.5 years. And then after 1.5 years, she decided that it was time for her to increase her intervention and her trying to cut more things. And so far she has been losing 100 pounds, and she was from size 28, now she's size 16, and she knows that she has to continue losing weight, and probably we're not going to decide to do any bariatric surgery for her. She's doing exercise, she has an excellent diet, and she's so happy because she's losing all this weight, and I'm happy too, of course.
The keys for success in the treatment of overweight and obese children are to assess BMI percentile at every visit, target the comorbidities, and involve the entire family as they make positive and small lifestyle changes. This segment highlights a few key resources available across the state. Consider reaching out to these organizations and utilizing the existing resources to create greater change in your community. The Foster Healthy Weight and Youth Clinic resources are free while supplies last and are available online for download at www.nebned.org. These resources include a clinician toolkit and pocket reference card with the algorithm, patient education brochures, clinic posters, and the Youth Physical Activity and Nutrition Assessment Form. This training video is also available to be shared. The Nutrition and Activity for Health program within the Nebraska Department of Health and Human Services is a good resource for additional information regarding the core prevention messages. To locate a registered dietitian in your area, visit the Nebraska Dietetic Association website at www.eatrightnebraska.org. Registered dietitians are trained nutrition experts that should be utilized in behavioral interventions, programs, and for referrals. For patients receiving or those eligible for federal assistance programs such as WIC, food stamps, and the National School Lunch Program, they can participate in the Nebraska Nutrition Education Program, which provides training opportunities on meal planning, shopping on a budget, healthy snacking, and more. To find out how to get eligible patients involved in the Nebraska Nutrition Program, call 1-877-611-4710. The Nebraska Medical Association advocates for physicians and the health of all Nebraskans. With a purpose to prevent overweight and obesity in Nebraska children, the NMA's Childhood Obesity Prevention Project works as a statewide collaboration to provide healthcare professionals access to and assistance with education, community outreach, policy advocacy, and clinical resources. Teach a Kid to Fish is a physician-directed nonprofit organization with a mission to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Teach a Kid to Fish has worked in collaboration on the clinical resources and has fostered the development of the NMA's Childhood Obesity Prevention Project. The website address is www.teachakidtofish.org. Live Well Omaha is a community-based partnership working together to achieve measurable improvements in nutrition, physical activity, and healthy living, supported by community collaboration and the environments in which they live for all Omaha children. Their efforts can be further explored at www.livewellomahakidsoneWord.org. When the Nebraska Healthcare Funding Act was passed in May 2001, local public health departments were established across the state to cover all Nebraska counties. You can find the contact information for your health department at http://www.dhs.ne.gov/puh/lhd.htm. You may be able to join an existing effort or assist in leading new community-wide strategies aimed at childhood obesity prevention. Nebraska Action for Healthy Kids, affiliated with National Action for Healthy Kids, is the only statewide nonprofit organization in Nebraska formed specifically to address the epidemic of overweight, sedentary, and undernourished youth by focusing on changes in schools to improve nutrition and increase physical activity. Nebraska Action for Healthy Kids is made up of state and local leaders in public health, education, and community outreach organizations. Join them. You can become a member at www.actionforhealthykids.org/Nebraska. The Nebraska Breastfeeding Coalition is a network of individual and organizational partners dedicated to improving the health of Nebraskans by making breastfeeding the norm through education, advocacy, and collaboration. You can join them by becoming a member at www.nebreastfeedingoneword.org.
Physicians are natural leaders to patients and their families. We know from studies that if a physician tells a family to consider a change in eating or exercise, families are 3 times more likely to at least follow up with the recommendation. Maybe not to sustain it, but at least follow up with the recommendation. So if we miss an opportunity in promoting healthy eating or physical activity, it's just as bad as missing an opportunity for immunization.
If it's coming from the physician, oftentimes parents will listen. When we talk about the food pyramid, we talk about encouraging all those fruits and vegetables. We have the posters up in the office and we have those conversations. That's a really great place to start in terms of preventing before it becomes a big issue. And those conversations can happen from the very first foods kids eat at 6 months.
I think all of us, we can be physician champions because it depends how much you like your practice, how much you love to be a pediatrician. It's the beauty of being a pediatrician is try to do prevention, as we hear prevention all the time. But when we are stuck with these kids that are 300 pounds, 200 pounds, it's impossible that we're going to let them go home without trying to do something. It's our job to try to prevent that things are getting worse. And that's what I'm trying to do with these kids. And I am telling you, I've been successful, and you can be too.
That the most important thing is to stay the course and working one-on-one individually with those children and families, and to assess all children for obesity risk, to deliver the consistent messages, to engage your clinic, to stay linked in with what's going on in your community and our statewide effort that we're starting. And I think we'll see some real changes.
Some people say that we need an ecological approach to the prevention of childhood obesity, and what that means is we can't just intervene at the doctor's office. We have to intervene or change the way we're living our lives in our homes, in our neighborhoods, in our church, make sure the physician is in fact measuring a child's body mass index and talking about nutrition and physical activity, for instance. We also need to be making changes at school. We need to be making policy changes at the broader level to make sure that we assure the conditions that children can be physically active and have access to good food.
As a healthcare provider, you can be an advocate by integrating Nebraska's Foster Healthy Weight and Youth model into practice. Equip your office with the tools and the patient educational materials you've just learned about. Engage the entire clinic in the effort and refer to community resources and programs. I encourage you to utilize Nebraska's clinical model to assess, prevent, and treat the epidemic of childhood obesity. Remember to chart BMI percentile for age on all patients. Allow for patient-driven goal setting using the Youth PAN form, and realize that it's the small changes we all make to yield big rewards in the health of the new generation. By advocating for environmental and policy changes in your community, you have the power to increase access to healthy foods and safe physical activity opportunities for all children, giving them a greater health today and in the future. Thank you for stepping up and being the champion that your patients and your community need. Together, we can foster healthy weight in youth.
For those wishing to receive continuing education credit, please access the Creighton CME Division's website at cme.creighton.edu and complete the post-test and evaluation. 70% accuracy is required on the post-test. A special thanks goes out to all the individuals who collaborated on the development of this training, dedicating time, talent, and expertise.